Welcome to the Deep Dive, the shortcut you need to be well-informed, fast. Today we are taking a scalpel to the pharmacology of acid-controlling drugs. This is a really critical area. It spans everything from simple OTC remedies all the way to high-stakes ICU medications. Our mission today is to distill the complex science and, crucially for you listening, integrate the absolute must-know nursing considerations for treating GI hyperacidity.
Yeah, and defining that term is important right out of the gate. When we talk about GI hyperfacidity, we mean, too much acid leading to conditions like GERD, peptic ulcer disease, PUD, and erosive esophagitis.
Things lots of people experience.
Exactly. But while these issues are common, if they're left unchecked, well, the consequences can escalate quickly. We're talking potential strictures, severe damage, even cancer down the line. So safe and effective drug delivery really requires you to understand the underlying cellular mechanism.
Absolutely. So we're going to tour the four major classes of acid control today. We've got antacids, those fast-acting neutralizers, then H2 receptor antagonists, or H2RAs, which are more like acid reducers.
Right.
Then the proton pump inhibitors, or PPIs, the total acid stoppers.
Big guns.
Yeah, and finally, a handful of unique miscellaneous drugs that have specific roles. Okay, let's unpack this by starting at the core of the problem, the stomach lining itself. We have these specialized cells there, chi cells, mucus cells, and the real star of our show today, the parietal cell. What exactly is this little factory doing in a healthy state?
Well, it's a beautifully balanced system, really. It's designed for both digestion and protection. The chi cells, they produce pepsinogen, which is the precursor to pepsin, the enzyme that helps break down proteins.
Okay.
The mucus cells secrete this bicarbonate-rich mucus that forms a vital protective coating over the stomach lining. But the parietal cell, that's the engine of acidity. It pumps out hydrochloric acid, HCl.
HCl, right. Strong stuff.
Very strong. It maintains the stomach's pH at a fierce 1 to 4. And this extreme acidity helps with digestion, but it also serves as a crucial first line of defense against ingested pathogens. And the production of that acid is the primary target for all these drugs we're discussing. The parietal cell gets signaled to produce acid by common triggers. Think food, caffeine, alcohol, chocolate, even stress.
Stress is a big one.
Definitely. And the cell wall has 3 types of receptors that act as sort of first messengers: acetylcholine, AC8, histamine, and gastrin. If any of those get occupied, the cell gets the signal, start making acid.
Okay, and this is where it gets really interesting, right? When histamine specifically lands on its receptor, it triggers a second messenger inside the cell, cyclic AMP or CAMP.
Exactly, CMP. And that CAMP provides the power, the fuel that runs the hydrogen-potassium-ATPase pump.
The proton pump.
That's the one. This pump is the final crucial step. It's literally the machine that pushes hydrogen ions out of the parietal cell to finally create that strong HCl in the stomach lumen.
Got it. So it's the bottleneck.
Precisely. Because this pump is the final common pathway, blocking it gives us the most profound acid control. And that's the mechanism we'll see later with the PPIs.
Okay. But before we leave the pathophysiology, we have to connect it to peptic ulcer disease, PUD. There's that bacterium, Helicobacter pylori.
Yes, H. pylori. It's implicated in a huge number of ulcers, up to 90% of gastric and duodenal ulcers, actually.
Wow. And the clinical focus here, then, is immediate and aggressive treatment if someone tests positive.
Absolutely. If the patient tests positive for H. pylori, the first-line treatment is a very specific, non-negotiable regimen. It's a 10 to 14-day course combining a PPI with 2 antibiotics. Usually that's clarithromycin plus either amoxicillin or metronidazole.
Okay, triple therapy, basically.
That's the standard, yes. We also need to quickly mention the critically ill patient population. Stress-related mucosal damage is a really high risk in patients on mechanical ventilation or those with long ICU stays, maybe more than a week.
Right, the stress ulcers.
Exactly. So for these high-risk patients, prophylaxis is the standard of care, usually using H2RAs or PPIs to keep acid levels down and prevent potentially catastrophic GI bleeding.
Makes sense. Okay, so we've mapped out the acid factory. Let's look at the oldest and maybe the fastest way we try to control it: antacids. These are everywhere, OTC. But you noted there are some major patient safety concerns sort of hidden in their basic chemistry.
Yeah, they seem simple, but you have to be careful. Their mechanism is beautifully simple, though. Antacids are basic compounds: salts of aluminum, magnesium, calcium, and sodium. They literally neutralize the existing gastric acidity by raising the pH.
So they just buffer the acid that's already there.
Correct. And it's crucial to remember they do not prevent the stomach from producing more acid. They just deal with what's present. They also seem to stimulate the stomach's natural defenses a bit, increasing mucus and prostaglandin secretion.
Okay, and the choice of which antacid salt is used. That's critical because the side effects can be completely opposite.
That's a key point. Aluminum salts and calcium salts are notorious for causing constipation.
Right, like Tums.
Yeah. Whereas magnesium salts, think milk of magnesia, cause the opposite. Diarrhea.
Ah, so that's why many products combine them, like aluminum and magnesium together.
Exactly. It's an attempt to balance out those bowel effects so you don't swing too far one way or the other.
Smart. But what about contraindications? Who absolutely shouldn't take certain types?
This is paramount for nursing care. If your patient has renal failure, you must avoid magnesium-containing antacids entirely. Magnesium is cleared by the kidneys, so if they're not working well, it can build up to toxic level.
Okay, that's a big one. Magnesium toxicity.
Huge. And for patients with hypertension or heart failure, you need to be very careful with high sodium products like sodium bicarbonate, Alka-Seltzer. The extra sodium can absolutely exacerbate fluid retention and strain the heart.
Got it. And what about using these things long term? Say someone popping calcium antacids constantly.
Yeah. Chronic high doses of calcium, especially if there's some underlying renal issue, can lead to something called milk alkali syndrome. That's headache, nausea, alkalosis, and dangerously high calcium levels, hypercalcemia.
Not good.
Not good at all. And another thing with chronic calcium use, when the patient stops taking them, they can get severe rebound hyperacidity. The stomach basically goes into overdrive making acid because it got used to being buffered all the time.
Wow. Okay. So lots to consider, even with simple antacids.
Yeah.
Now, what about drug interactions? You said this was arguably the biggest teaching point.
It really is. Antacids interfere with the absorption of countless other drugs.
Oh.
They do this through a few mechanisms, but mainly by changing the stomach's pH or by binding directly to the other drug, which is called chelation or adsorption.
Okay. So they mess with absorption. What's the practical advice then?
The golden rule: you must advise the listener, your patient, to dose interacting drugs, especially things like quinolone antibiotics, ciprofloxacin, levofloxacin, 1 to 2 hours before or after taking the antacid, not at the same time.
1 to 2 hours separation. And if they don't, you mentioned a huge reduction in antibiotic absorption.
It can be massive. For some quinolones, taking them with an antacid can reduce their absorption by over 50%. That could mean complete treatment failure for a serious infection.
Okay, that is a critical instruction. Huge safety liability if missed.
Absolutely. It hinges entirely on clear, effective patient teaching.
Okay, let's transition then. Moving from those physical neutralizers to chemical blockers, the H2 receptor antagonists, or H2RAs. These guys block the histamine receptor on the parietal cell, and that reduces acid secretion by, what, up to 90%?
That's right, up to 90%. They significantly dial back acid production.
So if PPIs, which we'll get to, are generally stronger, why do we still use H2RAs? Are there specific situations where this maybe less potent option is actually preferred?
That's a great question. H2RAs, especially the newer ones like famotidine, actually have a pretty good safety profile and fewer major drug interactions compared to the older one, cimetidine. They're often preferred for, say, simple, non-erosive GERD or for that stress ulcer prophylaxis we talked about in the ICU.
Okay.
Particularly if PPIs are maybe contraindicated for some reason, or if the patient is, concerned about the potential long-term effects of PPIs. Their mechanism is straightforward. They competitively block the H2 receptor, and by doing that, they make the parietal cell less sensitive not just to histamine, but also indirectly less responsive to HG and gastrin too.
So they dampen the signal overall.
They do, and generally they're well tolerated. But, and this is important, we must emphasize caution regarding CNS effects. Things like confusion and disorientation are known adverse effects, especially in older adults.
The elderly confusion risk.
Yes, and this requires really rigorous CNS assessment by the nurse when these drugs are being administered, especially in hospitalized older patients.
Okay. Now, you mentioned cimetidine, the older H2RA. That one seems to raise big red flags for drug interactions. How does it manage to be so problematic compared to, say, famotidine?
Cimetidine, or Tagamet, is a pretty strong inhibitor of the hepatic CYP450 enzyme system.
The liver enzymes that break down drugs.
Exactly. So by inhibiting those enzymes, cimetidine slows down the metabolism of many other drugs that rely on that same pathway. Think about drugs like warfarin, the anticoagulant, or phenytoin, the seizure medication.
Drugs with a narrow therapeutic index.
Precisely. So inhibiting their metabolism can lead to dangerously high, potentially toxic blood levels. Cimetidine also carries other potential adverse effects like impotence and gynecomastia, which you really don't see with famotidine. That's why famotidine has largely replaced it in practice.
Makes sense. And just a quick implementation note, if you're giving H2RAs intravenously, say, in the hospital.
Right, you have to monitor the patient very carefully for drops in blood pressure. Hypotension is a known risk, particularly if you infuse it too rapidly. So infusion rates must be carefully controlled and monitored.
Good clinical pearl. Okay, now we arrive at the powerhouse class, the proton pump inhibitors, or PPIs. You said these have largely replaced H2RAs as the first-line treatment for more severe hyperacidity.
hmm
How do they achieve that, like, almost total acid blockage?
It all comes back to that final step we talked about, that hydrogen-potassium-ATPase pump, the proton pump. PPIs, drugs like omeprazole, lansoprazole, pantoprazole, are actually prodrugs. They need the acid in the stomach to become active.
Well,
Once they're activated, they bind irreversibly to the proton pump itself.
irreversibly. So they permanently shut down that specific pump molecule.
Permanently. By shutting down that final step, they stop more than 90% of all acid secretion over a 24-hour period. Acid secretion won't actually return to normal until the parietal cell synthesizes entirely new pump molecules, which takes time.
Wow, that's profound inhibition.
It is, and this makes PPIs the first-line choice for the really severe conditions. Erosive esophagitis, GERD, that doesn't respond to H2RAs, treating PUD, and of course being the cornerstone of those H. pylori eradication therapies with antibiotics.
But there's always a but, isn't there? The clinical community is now raising some pretty serious red flags about the potential consequences of that total acid suppression, especially when these drugs are used long-term. What are the key safety warnings that have emerged?
Yeah, this is really important. When you essentially remove all the stomach acid, or most of it, you also remove that natural acid-mediated antimicrobial defense. This has led to pretty strong concerns about an increased risk of GI infections, particularly the nasty one, C. difficile.
C. diff, right? Hard to treat.
Very. And beyond infections, we now have specific warnings about other long-term risks. There's data suggesting an increased risk of osteoporosis, which can lead to wrist, hip, and spine fractures.
Fractures from an acid-blocking drug. Wow.
It seems counterintuitive, but it's likely related to decreased calcium absorption because you need acid for that. There are also issues with absorbing other nutrients, specifically magnesium depletion, hypomagnesemia, which can cause muscle cramps or even arrhythmias. And there's also an emerging, though still debated discussion about a possible link between chronic PPI use and cognitive issues like dementia.
That's a lot to consider, especially that fracture risk. That's a serious potential outcome if someone's taking these for months or years.
Absolutely. It requires careful risk-benefit assessment for long-term use. And in terms of drug interactions with PPIs, the big one to focus on is clopidogrel, the antiplatelet drug Plavix.
Okay, what's the issue there?
Omeprazole specifically is known to be a strong inhibitor of one of the CYP enzymes, CYP2C19. This particular enzyme is needed to activate clopidogrel in the body. So if omeprazole inhibits the enzyme,
Clopidogrel doesn't get activated properly and it won't work as well to prevent clots.
exactly, it could potentially decrease the drug's effectiveness, increasing the patient's risk of heart attack or stroke. So generally, if a patient needs both drugs, switching to a different PPI that doesn't have that strong CYP2C19 inhibition is often preferred.
Good to know. And when administering PPIs, especially the capsules like omeprazole, there's a really critical instruction about how the patient takes them, isn't there?
Yes, absolutely critical. First, they must be taken on an empty stomach, ideally 30 to 60 minutes before the first meal of the day. This timing ensures the drug is circulating and ready to block the pumps when they get stimulated by food.
Okay, empty stomach before breakfast usually.
Right. And second, because the capsules contain these specialized enteric-coated granules designed to survive the stomach acid, the capsule must be swallowed whole. Do not crush, open, or chew it.
Because that would destroy the drug before it can work.
Precisely. The acid would destroy it before it gets absorbed and reaches the parietal cells. The one exception is lansoprazole granules. Those can be sprinkled on a bit of applesauce, but they must be swallowed immediately without chewing.
Okay, clear instructions needed there. Let's move quickly to our final three miscellaneous acid-controlling agents. Starting with sucralfate. This one acts almost like a physical protection system, doesn't it? Like a bandage.
That's a perfect analogy. Sucralfate, or carafate, is a mucosal protectant. It actually needs an acidic environment to work properly. In acid, it forms this thick, viscous, sticky paste that binds directly to the exposed proteins at the base of an ulcer crater.
So it covers the sore spot.
Exactly. It acts like a liquid bandage, physically protecting the ulcerated area from further damage by pepsin and acid, which allows it to heal underneath. For implementation, it must be given on an empty stomach. And crucially, you have to avoid giving antacids within 30 minutes before or after the sucralfate dose.
Why is that?
Because the antacids would neutralize the stomach acid, and sucralfate needs that acid to activate and form its protective paste.
Got it. Okay, next up, misoprostol. This is a synthetic prostaglandin, right? And it has a very specific narrow indication.
That's right. Misoprostol, or cytotec, is used almost exclusively to prevent NSAID-induced ulcers. Drugs like ibuprofen or naproxen.
How does it work?
Well, NSAIDs work by blocking prostaglandins, but prostaglandins are actually protective for the stomach lining. Misoprostol essentially replaces those protective prostaglandins that the NSAIDs wiped out.
Makes sense, but there's a huge safety warning here, isn't there?
Massive. Misoprostol is an abortifacient. It causes uterine contractions and can induce miscarriage or premature labor. It is absolutely classified as a pregnancy category X drug, strictly contraindicated in anyone who is or might become pregnant. Extreme caution is needed.
Okay, category X cannot be overstated. Our last agent is the antiflatulent, simethicone. Molecule drops, gas X. What exactly is this doing to gas bubbles?
It's purely mechanical, really quite interesting. Simethicone works by altering the surface tension, or the elasticity, of those mucus-coated gas bubbles that get trapped in the GI tract.
So it makes them less bubbly.
Kind of. It causes the small, frothy bubbles to coalesce, to merge together into larger bubbles. These larger bubbles are then much easier for the patient to expel, either through, flatulence or belching.
Oh, okay. Gets the gas out. Any side effects or interactions?
Remarkably safe. It has essentially no listed adverse effects or major drug interactions because it's not absorbed systemically. It just works physically on the bubbles in the gut.
Okay, so we've covered the drugs. Now let's tie all this complex pharmacology directly into safe nursing practice using the nursing process framework. For you, the listener, integrating this knowledge is really paramount.
Absolutely. Let's start with assessment priorities. Beyond just charting the patient's GI symptoms like heartburn or pain, what are the crucial system-specific checks we absolutely have to perform before we even think about administering one of these drugs?
Right, you need a thorough baseline on key systems that could be affected. Because of those renal excretion issues with magnesium and potential accumulation, you must check renal function, BUN, creatinine levels, hepatic function 2, ALT, AST, especially with drugs metabolized by the liver like cimetidine.
Okay, kidneys and liver function first. What else?
If you're even considering giving a high-sodium antacid, you absolutely must assess the patient for any history of heart failure or hypertension. Giving them extra sodium could be dangerous. Good point. Cardiac status.
And don't forget that critical CNS check, especially for older adults receiving H2RAs. You need a baseline mental status. Are they alert and oriented? Because if they suddenly become confused or disoriented after starting the drug, you need to recognize that as a potential adverse effect. These assessments directly help prevent the complications we've been discussing.
Okay, so baseline assessment is key. Now, moving into implementation and patient teaching, these are really the moments of maximum risk reduction, where we can actively prevent problems. What are the absolute key instructions for the patient to ensure they get the therapeutic effects safely?
Okay, for antacids, the teaching has to reinforce the practical stuff. Liquid forms need to be shaken really well to disperse the ingredients. Chewable forms need to be thoroughly chewed before swallowing, and they should usually be taken with at least 8 ounces of water to help wash them down and aid distribution in the stomach.
And the timing.
Most importantly, reiterate, maybe even demonstrate on a clock face that 1 to 2 hour separation window from most other medications, especially those quinolone antibiotics we highlighted.
Got it. What about for PPIs?
For PPIs, emphasize that empty stomach rule. 30 to 60 minutes before the first meal. Reinforce the do not crush or chew for capsules like omeprazole unless it's specifically the lansoprazole granules meant for sprinkling.
Okay. And any general dietary advice for patients with GERD or PUD?
Yes, definitely. While the drugs are the main treatment, lifestyle helps. Advise them on common triggers that aggravate hyperacidity. Things like avoiding black pepper, excessive caffeine, alcohol, really harsh spices, and also extremes in food temperature. Very hot or very cold foods can sometimes be irritating.
Good practical tips. And finally, let's circle back to that complex H. pylori regimen. You said compliance is everything here.
It is absolutely the hinge upon which treatment success or failure turns. You, as the nurse, must emphasize the absolute necessity of taking the full multi-drug protocol, including every single dose of the antibiotics, exactly as prescribed for the full 10 or 14 days.
No stopping early because they feel better.
Absolutely not. Recurrence of the ulcer or failure to eradicate the bacteria is almost always linked to non-adherence to that complex regimen. Then, in the evaluation phase, of course you monitor for therapeutic success. Ask the patient, is the pain gone? Is that feeling of fullness or burning better? But you must also critically monitor for the adverse effects we discussed. Are they getting constipated from aluminum or calcium or diarrhea from magnesium? Any signs of acid rebound after stopping?
Milk alkali syndrome.
Exactly. Watch for symptoms of milk alkali syndrome if they're on high-dose calcium or have renal issues. Monitor for signs of systemic alkalosis. And always, always instruct the patient and monitor yourself for any signs of GI bleeding, things like black, tarry stools, or vomiting blood, or material that looks like coffee grounds. Those need immediate reporting.
Excellent summary of the nursing process application. Okay, that was a tremendous deep dive into a complex topic. To recap the core mechanisms just one last time for everyone, antacids simply neutralize existing acid. H2RAs reduce acid production by competitively blocking histamine receptors on the parietal cells. And the PPIs are the most powerful, achieving almost total acid blockage by irreversibly shutting down that final step, the hydrogen-potassium-ATPase pump.
Right. And, we know that PPIs offer incredibly effective, sometimes even life-saving treatment for serious disorders like erosive esophagitis or bleeding ulcers. But given the increasing amount of data we're seeing now on potential long-term risks, specifically things like osteoporosis and fractures, C. difficile infections, magnesium depletion, and maybe even potential links to cognitive issues, it really raises an important question for us clinically, doesn't it?
What's the question?
How must our clinical guidelines adapt moving forward? How do we balance the clear benefit of aggressive treatment for severe hyperacidity with the imperative need to protect patients from potential long-term complications? Especially, perhaps, for those patients whose symptoms are milder and might potentially be managed effectively with less profound acid suppression, like H2RAs, or even just lifestyle changes. It's a balancing act we need to keep evaluating.
That is a really provocative thought, to end on balancing potent efficacy against long-term safety in an era of chronic medication use, something definitely for all of us to keep in mind. Thank you for that fantastic breakdown, and thank you for tuning in to the deep dive.